tout le monde. I hope you're doing well. I'm Linda Silas. I'm National President for the Nurses Federation of Nurses Union. Don't know who I am this morning. Will help. And I'll be your host this morning. Before we get started, just wanted to reminding all our participants, the session will be in English only. But if you have any questions in French, please just type them in the chat and we'll make a pleasure to answer them. Juste pour vous rappeler, notre session va être en anglais seulement, mais si vous avez des questions, s'il vous plaît, n'hésitez pas à le mettre dans notre chat et on va vous le répondre aussitôt que possible. As you all know, mental health and wellness is important to all of us. And when you're a nurse, when you're a healthcare professional, I don't want to say it's even more important, but we put a lot of emphasis on it. And it's important that we talk about what kind of best care we can provide to our communities, but best care we can provide to our healthcare workers. And that's why these seminars have been developed and produced. Our first report on mental health of nurses was in 2019 when Dr. Nick Carlton from U of Regina and his team really developed a survey of nurses' mental health. And I remember when I got the preliminary report, I said, we can't publish this. This is too awful. But we needed to publish it to alert everyone and to alert nurses themselves that we needed to better take care of ourselves, but better support them in these drive. So this is the third and final webinar in a series that's about nurses' mental health. And it's in collaboration with the Canadian Nurses Association and the Canadian Federation of Mental Health Nurses and CFNU, which the two first series was Proven Solution to Enhance Nurses' Wellness and By Culture, By Design, Caring for Your Healthcare Professional. So we went from identifying the problems to giving you solutions. And now we're going to talk to two experts to really look on how does it work? How do we evaluate it and move forward? The two experts that we're going to be working with are here to help us better understand and strengthen our psychological well-being in the workplace and really focus in the workplace. Carl Kemp from the Health Standard Organization is going to take us through the HSO Global Workforce Survey and how it can be used to create a better psychological health and safety in the workplace. Alison Lee is joining us from the Royal College of Physicians and Surgeons of Canada and to discuss Canada's health workforce well-being plan and how does it impact nurses, but how does it impact every other healthcare provider. The two speakers are going to present. Their full bios are in the chat and also were published during the promotion of this webinar, and you can ask questions at the end. So before I go to Carl Kemp is the Director of Methods and Analytics, and Reporting on Health Standards Organization. In his role, he's served as Produce Manager for HSO Global Workforce Survey and leads on data analytic vision for the organization. He does very different work than I do every day. But Kyle has a passion for bringing data to life and has had the privilege of leading and working with high-performing teams over his 20 years in healthcare. He has a PhD from University of Calgary with a focus on health service research. Please help me welcome Kyle to the virtual stage, and we'll hear his presentation. Kyle, please.
Hello, everyone. I'm delighted to be here today, and thank you, Linda, for that warm welcome. Just as I pull up my slides here, I'd just like to acknowledge that I have the pleasure and gratitude to live, work, and play on the territories of the traditional territories, rather, the peoples of Treaty 7. Located in the city of Calgary here in southern Alberta. And I'd also like to mention that the city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And thank you once again for that warm welcome, and delighted to see so many folks online today. All right, just a brief agenda for our time together here today. So I'm going to speak a little bit about the Global Workforce Survey. I'll speak to the rationale as to why it was developed and to speak a little bit on that. I'll also delve into some of the survey content and resources that we provide to our clients in use of the survey. I'm also going to point to some of the client feedback that we've received from implementation. I'll also speak to the survey results and some of the actionable insights in the context of psychological safety, burnout, and similar points. I'm also going to highlight some of the collaboration that we have not only with researchers across Canada, but also with Health Workforce Canada. And I'm sure many of you are familiar with their Health Workforce dashboards. And then I'll just open it up for discussion afterwards, of course. So just a bit of a lead in as to the raison d'etre, the reason why we have the Global Workforce Survey. And as Linda mentioned off the top, I'm really, really motivated by data and analytics and really a culture of measurement in our healthcare system. And this quote that you see on the screen here, there is no quality of care without a healthy, competent workforce. I'm sure that resonates with many, if not all of you. It was in an article recently published by our CEO with collaborators in patient safety from across Canada in Healthcare Quarterly, which is a Longwoods Journal series. And as I mentioned, it's really, really crucial. Our health workforce is our most precious resource here, and it's really crucial to gain their insights from a workforce development, retention, and experience perspective, making sure that everyone in the healthcare workforce, from the bedside to the back room to the C-suite, feels supported and really helped in their journey to develop and foster that trust. So no secret to many, we are really being, pushed to the limit in some instances by some of the things that have played out over the last few years, COVID being a big one, of course, but we're also seeing a demographic shift here in Canada. No mystery to all that Canadians are living longer. And with that, they're living longer with one or more multiple chronic conditions, which obviously those complex healthcare needs really up the game in terms of the demand on our healthcare workforce in caring for all of these folks. Secondly, unfortunately, we've seen in recent years, particularly, last few with wildfires here in Canada, and the impacts that climate change and those types of wildfire events and other climatic events, the strain that it puts on our healthcare providers, our healthcare systems, et cetera. I highlighted off the top that I'm in Calgary and, just wanted to take a moment to recognize the people that are being impacted by wildfires in our north here, in Northwest Territories in particularly, and other provinces. And, with that, of course, some of the untoward effects of that. The air quality index is an 11 here in Calgary today. So if anyone is having respiratory issues or whatnot, obviously that impacts their issues and their challenges around managing those conditions as well. And one of the things too, there are some excellent technological advances that have come into healthcare in the last few years, but I would argue that although they might increase some efficiency perspectives, it's not going to help solve everything. So it really, we need to rely on some other things here. So just speaking to the Global Workforce Survey, back in 2020, we started consulting with organizations, and we consulted, as you see here, with 37 organizations, clients from across Canada, across 19 different healthcare sectors. The first thing that they outlined was really the need to modernize our surveys. Up until 2020, 2021, for many of you who are familiar, Accreditation Canada and the like, we had two surveys that we had in play for our client organizations. The first being the Work-Life Pulse, and the second being the Canadian Patient Safety Culture Survey. Two excellent surveys, but developed perhaps a decade earlier, and perhaps things hadn't evolved over time. So the need to modernize the survey, not just from a content perspective, but also to reduce survey fatigue. Having two surveys could be a little bit clunky. Perhaps you're burdening the staff twice. Is there a way maybe that we can condense the items, put it all into one survey, and only ask the staff to fill it out once? And from a measurement perspective too, it really, really helps with any, policy changes or changes in the workplace that might have been instituted as well. So capturing it all in the same moment, all at once was key from our feedback gathered. The third piece was really around linking the results to action planning. So we're not just doing recreational data collection. We're not just doing surveys because folks don't have anything better to do. Quite the opposite, of course. And we all know we've been asked to take multiple surveys, whether it's with our banking institution, a restaurant, Ticketmaster, or indeed in the workplace. And one of the things that we really would like to see is the impact of that data and that data for change, not just for data's sake. And then lastly, although having a standardized tool is always excellent, we wanted to ensure with our clients from their feedback that we had some flexibility and some customization in the survey as well. And I'll get to that in a few slides here. So just an overview of the instrument itself. As we see, it's a 65-item survey. It takes about 15 minutes to administer, and really important to highlight that it's designed for all members of the workforce. I mentioned from the bedside to the back room, to the C-suite, to admin staff, to the labs. Every touch point in the healthcare system will take this survey. And it's important to highlight that it aligns with our leadership standard, and it is, since May of last year, a required component for all organizations enrolled in our accreditation programs. And I'll speak to that a little bit more in a few moments. So from a value principle, I'm sure this will resonate with many, if not all of you on the call. So really, the ability that it reflects the workforce experience and their day-to-day across regions and many care settings. So we can accurately and timely measure across all of those touch points. And really, we all know that workforce experience is indeed a leading indicator of patient outcomes. So things like patient safety and those types of pieces as well. And really the idea is I spoke to the necessary, aspect of not just capturing data, but really using it to capture those insights and to guide some interventions that we spoke to earlier in the series. So things around burnout and safety culture, which I'll speak to a little bit as well. Obviously, benchmarking, that's something that came in loud and clear from our clients as well. Not just knowing my results, but where I stand compared to peers like myself, as well as across different geographies, roles, and different timeframes, so change over time as well. And then we could also argue that it would promote transparency and accountability in workforce well-being and safety, having that hard quantitative data to support decision-making, as well as policy development and strategic planning. And then, of course, from a sustainability and planning perspective, I'll speak to our collaboration a little bit later with Health Workforce Canada. So firstly, as I mentioned, we previously had those two surveys, but it's really not just bringing two surveys together and having 1 + 1 + 2, but rather, a chance to revamp the content, make it a bit more contemporary, and include topics that perhaps have not been captured in prior instruments. So from a work-life perspective, I won't speak to all of these, of course, but we see some of the main pain points around retention and turnover, even the quality of supervision that folks receive in their workplace. And then from a safety culture perspective, obviously, burnout is a huge issue. Even looking at psychological health and safety, as well as workplace health and safety, that physical aspect. And then in terms of some of the questions, just to highlight, and obviously not going to highlight all 65 items, but what we see is we see some of the dimensions in the survey. So we see things like job characteristics, immediate supervisor, and leadership, and the corresponding amount of items in each of those dimensions. And you can see some example questions right there. So really around job expectations and time pressures, as well as getting feedback from supervisors and considerations of improvements for patient safety. And really the trust in leadership piece as well, which we've seen is so crucial in fostering a just culture and a psychologically safe workplace. Some other dimensions in the survey around well-being and engagement. So we see things like burnout, as well as the respondents' recommendation of the organization as a place to work. So a bit of a big dot measure there. We also see elements of people-centered care, as well as treating patients with respect and dignity, and making sure that patients and families and caregivers are actively involved in care decisions. And then, of course, perhaps, not the most crucial, maybe, but one of the most crucial, if not at the top of the podium, patient safety. So, really, even asking questions like, in the last 12 months, how many times have you had to care for more patients than you felt that you could safely care for? So, that is a huge indicator of patient safety in the eyes of our respondents. I talked about the leadership and how that's been developed in coordination with the leadership standard, but we've also mapped to other national standards of Canada, so long-term care services, as well as mental health and addictions. And many of you are probably familiar as well as with the National Standard of Canada for Psychological Health and Safety from CSA, as well as the BNQ in Quebec. So not only does it measure those features, we've also mapped to those elements as well too, making sure that, we're in alignment with those. I spoke earlier about the desire for flexibility and customizable content. So in addition to the core survey, as you can see in the second bullet point, organizations can add custom questions. So if they want to add any different demographic or background questions, we've had client organizations asking about their mission and value statement, if the staff were aware of those and if they felt that they enact those in their daily work, just an example there. But also the update of the patient terminology. One of the key things that came out of our pilot work when we were developing the survey is that the previous tools also tended to have a bit of an acute care focus. So also being able to update that terminology. So if the survey is being administered in a long-term care setting, it would say resident. And if it's in a community-based setting, it may say client or a home care setting as well. So that ability is there. And then there's also one open-ended comment question to collect qualitative feedback, which asks respondents at the completion of the survey if they have any suggestions to improve patient safety in their organization. Some of the resources that our clients receive with the survey as well is they receive a comprehensive toolkit that includes things like a creation and management guide, a reporting guide, a crosswalk to other surveys as well. We heard loud and clear that although we're shifting away from the Canadian Patient Safety Culture Survey and the Work-Life Pulse, it's really important for our organizations to be able to do those comparisons to those prior surveys to see if they're still moving in the right direction. And we also provide some resources around FAQs as well too. So with the understanding that many clients, this might be their first foray in launching a survey such as this one. So giving them the appropriate guidance, not only around survey deployment, but on how to interpret the results and use it for their action planning to be successful. I also highlighted some of the collaboration around research. So Harm Evaluated, as we see, is a Canadian Institute for Health Research funded pan-Canadian study centered out of the University of Toronto. And as a huge endorsement for our survey, they selected our item for inclusion in their core data set. And the overall aim of the Harm Evaluated work and study is to identify hospital level factors which impact patient safety in those four safety relevant domains. So we see patient safety culture, safety strategies, staffing, as well as volume and capacity. And one of the things that they are doing, which is super neat about this study, is they're collecting an inventory of safety strategies that are in use in Canadian hospitals to really try to discern, as we're all aware, there are, hundreds, if not thousands of safety strategies out there. What are the ones that really, through the data, are showing a bit of a signal for difference? And perhaps most importantly, what are the things that we've just tended to do for years upon years that maybe don't have a strong evidence base or not supported in the data or the literature? So maybe some of that de-implementation piece comes into play here, which of course would be welcome, I'm sure, for many on the call here. One of the things that we do as well with our client organization is it's a self-service tool, the GWS, the Global Workforce Survey. So not only do they send out the survey to their workforce, it also collects their responses for them and it gives it back to them in a dashboard that you see a bit of a screenshot here. So it provides some tables and graphs. It provides all results, but it also provides a sentiment. So it'll give you the positive, the negative, as well as the neutral responses. And that also, when providing the data in that format, it provides some insights to support learning and continuous improvement activities. one of the things that may not be appreciated in that screenshot is that not only can organizations see things from a 30,000-foot view, they can also start to delve into different groups of audiences or groups of workforce members based on job role, location, even some demographics as well. So different age groups, even things like tenure within the organization are things differentially impacting employees who have been there longer versus a shorter time, those types of elements. And I'll get to that in a few moments with a bit of a peek at our 2022 results. Just highlighting in our pilot and our first wave of implementation, so this speaks to the larger development work that we did. We can just see the number of organizations and the number of locations. So we see in that 2022 first wave of implementation, we had over 10,000 respondents. And we see the response rate was about 31% in the organizations that administered the survey. We had one small organization that had 98% response rate, just tremendous. And of course, we did have a few organizations a bit on the lower end, speaking to some of the challenges, I guess, with administering surveys of this type. And when we sent out the survey as well, we also wanted to make sure that there were some metrics in there around ability to comprehend, the length of the survey, those types of things. And we see some of these metrics right here. So it was very highly regarded and very well received on part of our pilot and first wave recipients. Just speaking to the 2022 data, just looking at some of the things that we've heard, and this will probably resonate with many, if not all of you on the call, high levels of burnout. And this isn't just limited to nurses, of course. It was seen, across multiple groups of employees, some time pressures and expectations of the job, a lack of positive recognition, perhaps from leadership. And that perhaps delves into the trust of senior managers and executives, and as well as reports that psychological safety was challenging in many instances. So as we know, different work groups based on demographics, job role, setting, etc., may be more preferentially impacted or may report some differences in this data. So at a very high level, just looking at, once again, the 2022 data, which will be on the next few slides here as well, just a question about feeling burned out from my job. And you see about a third of respondents responded that they feel burned out from their job once a week or more frequently. And when we start to drill down into the data a little bit, as I spoke to before, there's a direct correlation with the number of hours worked per week, not pretty intuitive as we see that the work demands ramp up, feelings of burnout also do. And then looking at tenure in the organization as well, too. So we see that, a little bit higher, 6 to 10 years, 11 plus years at 35% as well. So a little bit there. Perhaps there's a bit of a honeymoon phase in that first year with an organization, and then that maybe erodes over time. Secondly, looking at feelings about leaving the job. So, from a retention perspective, this very much hits home, and we see about a third of respondents as well strongly agreed with the statement. Looking into different job categories, and Linda had mentioned burnout and attrition off the top as well, seeing that nurses were very, very impacted on this question, 43% reporting from the data. And this isn't limited to acute care, of course, it's all touch points in the healthcare system. And then when we look into that nurses only group and starting to drill into the age group, we see some really interesting findings as well that, it's not just directly related to age. We can see that 25 to 34 actually had the highest. So, you start to think about, perhaps work-life balance or other things that come into play. Perhaps people have young families at that stage of life as well, and perhaps that's reflected in the data here. And then a question around leadership or management and trust in those folks. So you could see that 62% strongly agreed that they could be trusted, or the flip side being 38% either neutral or negative. And we see a bit of a relationship, tenure at the organization, speaking about perhaps a bit to that honeymoon effect, perhaps people feeling a little bit more jaded over time, or that trust erodes over time rather with tenure within an organization. And then once again, with job category, some of the lowest results, seeing the nurses specifically, about half only saying that they can be trusted. Lastly, I just wanted to come back to another piece of collaboration. So since May of this year, we're very pleased to be collaborating with Health Workforce Canada. They have a health worker wellness module that you see here on the page. That's their splash page on their website. I encourage you to check it out if you haven't yet. But they bring together in other pages of their dashboard and other dashboards, they bring together many administrative measures. So things around FTE, head counts. You can drill down by profession and different types of nurses as well in some instances. Looking at perhaps where we have some disparities, where we have some shortages in head counts. And obviously that goes hand in hand with attrition, burnout, and those types of elements that we bring through the survey. So really pleased to highlight that 10 of our questions from our 2022 data are highlighted on that webpage. And if you just Google Health Workforce Canada dashboards, it should take you right there. As I mentioned earlier, that comes from over 10,000 respondents from workers across Canada. And it really speaks to the focus upon physical and mental health, the psychological safety piece as well of healthcare providers, including nurses, and really helps to capture the current situation. Once again, coming back to meaningful measurement and providing information to support and strengthen action planning and health workforce development. So with that, I just wanted to take a quick moment to thank you all for your attendance today. Really appreciate the invite to present on the tool, and I look forward to your questions. And I'll just leave it up for another second or two, or if you wanted to scan the QR code, or if you had interest, please go ahead. And I've also included my email if you feel like reaching out afterwards as well. And I'll just stop sharing there. Thank you once again.
There. Thank you very much, Kyle. Very interesting, how a survey can help us build the evidence, of course, but also it's about building standards, making sure that we do better next time around the surveys there. What I'd really like to see is that these surveys be mandatory, not just a flash in the pan. One of the questions we got, Kyle, and you might be able to put it into the chat box, is how do we get those surveys? How do we get our employers to look at these surveys? Because what we hear as Nurses Union, very similar to the statistics you showed, is there's burnout, and then the new thing is moral distress, because their number one concern is about workload. They can't do their job, and they go home and they really feel distressed about it. Sylvia, you asked a question about nurse-patient ratios. That could be a session by itself, but just go on BCNU's website. I just want to say that it's progressing very well, and so is it in Nova Scotia. So go there. Now, thanking Kyle for his presentation, we'll go for our next speaker, which is Allison Lee. Allison is the program manager at the Royal College of Physicians and Surgeons of Canada. She's passionate about gerontology and seniors care, and has dedicated her career to advancing healthcare needs and transforming work environment. You could be a good union activist, Allison, and different system in Canada. So right now, she leads the Canada Health Workforce Well-Being Plan and bringing collaborators together through the health workforce to create an action plan to address the well-being and burnout. So please help me welcome Allison to join us today. Allison?
Thanks so much, Linda. I will very much keep that in mind, the union work for the future. So thank you for that. Let me just pull up my slides. And I would like to first acknowledge the land that I'm gathered here in Toronto, which has been the traditional territory of many nations, including the Anishinaabe, the Haudenosaunee, and the Wendat people. Today, it is home to diverse First Nations, Inuit, and Métis communities, and is also covered by Treaty 13 with the Mississaugas of the Credit. As a part of this project, as we will all come to learn, it is a deeply collaborative project. We recognize a lot of the inequities that have happened in healthcare and continue to impact Indigenous people, and we are committed to really advancing equity, listening to Indigenous voices, making sure that decisions are made with them at the forefront of the work that we are doing, and weaving principles of respect and reciprocity into the work that we were doing. So today, folks, I'm here to share about Canada's Health Workforce Wellbeing Plan. I know it is a mouthful. We will come up with, I'm sure, a much shorter name as we go. A little bit of a project summary along the way. So we are a Health Canada funded initiative until March 31st, 2028. We are inspired by the National Academy of Medicine. A number of years ago, they came together. They saw an issue, especially pre and during COVID, about what burnout was doing, what fulfillment was doing, what the impact of well-being looked like on healthcare workers. What they did was they brought together a clinician well-being collaborative. So they brought together a steering group that really was gearing towards how can we address these issues? How can we address what retention looks like? How can we address what burnout looks like along the way? Their overall goal of their project, and ultimately our project along the way, is to develop an action plan for the health workforce well-being. So how are we getting there? Really three main components that we're looking at, and we will do a greater focus on the measurement piece today, is establishing a national collaborative. So really looking at an interdisciplinary steering committee. We currently have over 35 organizations across the health workforce in Canada presented. We're convening and have convened 6 working groups that are developing policy and program recommendations based on the 6 key focus areas that we've seen. And lastly, utilizing a validated survey metric to inform quality improvement of that health workforce. So what does the national collaborative look like? So currently we have 35 members of the collaborative. It was very, very clear right off the bat when we brought this project together from our first steering committee that we ever put together, from our funders from Health Canada, that there is an intense need to bring together the diversity of the health workforce together. Addressing an issue alone for one area of the health workforce is not addressing really the health system as a whole. So we now have over 17 groups of diverse healthcare workers presented. Physicians, nurses, radiation technologists, occupational therapists, PTs, chiropractors, psychotherapists, the list goes on. We continue to bring on as many folks as possible where well-being is a part of the mandate of the work that they are doing. So anywhere there is alignment, anywhere we can collaborate together to really accentuate their work, but also not duplicate work at the end of the day. How do we bring folks together to make sure that we are advancing the work in this healthcare system? The goal of this project is to expand the collaborative until March of 2026. So next year, we're then going to switch a little bit of that focus into a little bit of that evidence-based intervention. So where does it come into measurement? How are we recruiting for environments that are able to put in interventions along the way? Part of the reason for that capping even of timing is we want to make sure that folks that are joining the collaborative have as much of their voice possible through the entirety of the project. And we just recognize that after March 2026, they won't be able to contribute as much as the folks that are already existing on the project. So our working groups are split into 6 different focus areas: creating positive work and learning environments, investing in measurement and research, supporting mental health and stigma, minimizing administrative burden, institutionalizing well-being as a long-term value, and recruiting and retaining a diverse and inclusive workforce. I'm sure as many of you have noted, have experienced in your workplaces or as leaders, that these are not necessarily surprising. Mental health, administrative burden, long-term value, culture, recruiting and retaining. These are 6 of the things that we saw in the National Academy of Medicine working groups. But what we had done is we took a thematic analysis in the Canadian literature, and not surprisingly, very similar 6. We have tweaked a little bit of the wording along the way. And really the goal in these focus areas is that we are able to see what is it in literature, what is it in programs right now, in workplaces, in community health settings that are working within these 6 areas, and how can we bring it all together? How can we make recommendations? How can we bring implementations together? So what we're seeing in the working group compositions is every group has about 10 to 13 members, 2 to 3 co-chairs. Every group has a minimum of at least four professions represented, four different areas across Canada, different career stages, rural, urban, any DEI specific things that were noted on applications, language, anything like that. We've included them to be as diverse as possible within all of the groups. We recognize that 10 to 13 folks is not going to be the end all to what we're looking at. We're bringing subject matter experts into a group to distill that knowledge, to bring together experience. And really the goal out of the working groups as deliverables are coming out is that we will have the opportunity to have town halls along the way where we are gathering more and more feedback on those recommendations coming out. Do they look like they can be tested along the way? Are there things that we are missing along the way? The main deliverables coming out of these working groups are two things. So the first really are policy recommendations. I'm sure many of us are familiar with what it is like to advocate, to rally towards the government, and really the strength of this project and what we see bringing together folks for the collaborative is how are we doing this from an interdisciplinary perspective at the end of the day? So when it comes to culture, when it comes to workplace environment, when it comes to administrative burden, these are not issues that are sole issues within each profession. Each profession may deal with them in different ways, may experience them to different levels in different ways. But really, how are we presenting these issues as a whole within the system towards the government? How are we rallying together? So the strength of the recommendations coming out from a policy perspective is that it is an interdisciplinary perspective coming into that policy recommendation. The second piece of that is a program recommendation. So really where we're seeing this is we know there are a good number of existing programs. We know there are a good number of ideas and thoughts of programs out there. How do we meld it all together to make recommendations within the 6 working groups of really tangible pieces that can then go into an environment, go into a hospital unit, go into a community health setting where it can be implemented for a short-term period of time and then tested along the way? We see this time and time again as we do this project that changes to the healthcare system and changes to units happen all the time. I think what we often fail to see, and for so many reasons, for funding, for staffing, for the fact that everyone has a million things on their plate, is there isn't necessarily the ability to test those things, to test those interventions out, to have the time to be able to put in an implementation, to test the implementation and demonstrate whether or not it has been effective or not. So that's where we see measurement as a part of this project that has continually grown along the way. When we first started this project, it really shifted from a national to a needs-based. It was very well said by Kyle that we really, we're not looking to measure for measurement's sake at the end of the day. Nobody wants another survey that is not going to make a difference. We want to have a survey that is going to make an impact, that we are going to see change in, that is not taking too long along the way. So that shifted from national to needs-based. We really quickly learned that you can't change what you don't measure. So we were really committed to evidence-based interventions, but really building upon what is out there already and providing a piece of a tool that is going to be helpful for folks along the way. So it then has delineated into 2 parts of measurement. That first one being the opportunity for organizations or units who don't have a baseline or are looking for a baseline specifically to well-being that they can continue to deploy along the way with the measurement. And then a second piece that we will get to as well when it comes to interventions. So we're really looking at identifying gaps. So what is not met in the Canadian healthcare system? What is not there in the measurement infrastructure, the benchmark data, collaboration opportunities with organizations, units, hospitals, health settings? And then how can we bring that all together to develop an action plan, develop a business plan, and develop leadership well-being specifically within this sphere? So as we went along in the project, the Professional Fulfillment Index was chosen. It's a very, very short and sweet index from Stanford University, where we were keen to be able to partner with them on looking at Canadian data with these pieces. All in all, with the measure that we're looking at, it's about 4 measures within it and then 2 supporting evaluation measures as well. And all in all, with an open-ended question, it took about 5 minutes in our pilot environment for folks to be able to take this survey to share what was happening in their environments. The really second beautiful part about the PFI other than the fact that it was affordable, it's easy to disseminate, was that it becomes a self-measure for the folks that are taking it as well. So there's a cutoff line for the burnout measure, fulfillment measure, and it provides an opportunity for the environments where they were doing the surveying to be able to put resources, make sure that there were folks on the back end of it where they were reaching out to folks, that they had a place to go if they needed someone to talk to, that they could continue to take this evaluation because the PFI is online and available and free to track for yourself, as something that could also be a tool that is used personally as well. So in that pilot data that we did a very small pilot population at the University of Alberta with their PGME residents. It was about a 30% completion rate, took a little less than 5 minutes all in all. And we saw really, really rich qualitative and quantitative data coming out. It is still being analyzed right now, so I don't have all the information for everybody. But we saw a lot of folks who shared things that were going to make their environment better. So the open-ended question that was asked is, if you can make one change in your environment to improve your well-being, what would it be? And we saw so many great suggestions: reducing admin burden, transforming workplace culture, enhancing comprehensive well-being support, eliminating restructures, extending call shifts, increasing staffing and support. And really what we saw in the top 10 things that kept coming out were things that fit within those 6 working groups very naturally. So what we're going to see is, out of those results, is them funneling into the 6 different working groups to influence the recommendations that are coming out. Timelines for the overall project are looking at a baseline survey coming into this fall. So we have a good number of organizations that will be joining us in the late September to late October to disseminate the survey along the way. And then we're looking at interventions next year as recommendations come out for more unit level environments that we'll be able to implement along the way. And then the PFI being pre and post tested to that intervention. So just a very short summary of organization surveying right now. So we see Association of Faculties of Medicine, we see medical radiation technologists, pediatric nurses, physician assistants, radiologists, dental assistants, dental hygienists, sorry. The CFNU is surveying along the way, home care associations, psychiatrists, nurse practitioners, pediatric chairs, rural physicians, and speech language audiology. And this is just really the first group that we are doing. We are meeting with much more unit level hospitals along the way, and we're looking at what that second cohort of surveying may look like into the future. And really, what does it look like when it comes to these measurement goals? So really supporting the working group. So as the experts, as the subject matter experts come together, they have the tangible resources, policies, interventions that they're looking at that can be deployed amongst different healthcare environments. So how are we all working together to look at these interventions? How can they be put into an environment so we can test them? Really looking at measurement infrastructure to support groups for validated metrics. We have a good chunk of groups that are going to be using the PFI. How can that data be looked at across the board from an aggregated level? We know there are several more surveys along the way that have integrated the PFI into some of the work that they're doing and existing surveying. How can we collaboratively build an evidence base of interventions for the Canadian public healthcare context that leads straight into our advocacy work? What is it that we're seeing out of these 6 working groups, and how can we rally the public to rally the public healthcare setting for our administrators, for our government to really get behind what needs to change? And then how can we present that from an interdisciplinary point of view? So we are about halfway through the project. The measurement really is looking at a kickoff coming into the fall. But if there are any questions, please email us at wellbeinggrants@royalcollege.ca. We're happy to answer any questions along the way. I know there will be a time for Q&A. But if there's interest in surveying, if there's interest in your association being a part of the project, or your unit level environments that are interested in implementing or testing along the way, that is where you can reach us. And I will pass it back over.
Oh, thank you very much, Allison. I hope you see the little hearts and the clapping of the hands. to both of you. Honestly, the presentation were for too scientific. It was very interesting and to the point. I love the fact that, Allison, you said it's a system issue. It's not one profession or one group of workers. It's a healthcare system issue that we have to deal with. I've always said we did a disservice to healthcare workers from day one. We put patient safety as number one, and that is key. That's our heart, that's our work. But the whole occupational health and safety, both physically and mentally, was always on the back burner. And the work of you and Kyle really is bringing that forward. So I thank you very much. I'll ask the magicians behind to put you back on screen, and we will go directly to Q&As. I have about 13 minutes for Q&A, so we're pretty good. Now, I don't know if somebody in the background asked you, Allison and Kyle, if we could share your PowerPoint. So if not, tell one of the magicians. If yes, we will put your PowerPoints in the chat so they can have it as a reference. So that was the first question coming from the participants on the last presentation. One of the questions that was asked, and Allison, you talked a bit about it, was stigma. And the question was, have you seen much improvement in filling in all their surveys of nurses or healthcare workers dealing with stigma already with mental health issues? And if they fill in the questionnaire, there was a fear of stigma there. So we've seen an improvement on that, either of you or both of you, honestly.
Yeah, happy to take a first stab. So one of the things that we've seen in our pilot, but also as we've been working with organizations, is how is the data getting back and what is the clarity on what the data is used for along the way. So what we saw in even our pilot study is we were very clear that the project was coming back to the environments, but was also completely anonymous. So it was done through a third party, not-for-profit. It was coming back to your environments. It was being linked to resources, but it was also looping back to how is this going to impact you along the way. So what we found with Sigma was absolutely it's present, but the addressing of it makes a difference. The clarity of what the survey was going to be used for, what their data was going to be used for, that their mental health with the resources at the end of the survey was not being taken for taken's sake. There was a meaning to it. It definitely, we found, made a difference in the percentage of survey takers because we definitely anticipated a lower amount.
Kyle?
Sure. And one thing I might add, kind of a similar experience as Allison. One of the interesting things that we've seen in the data from our 10,000 respondents in that first wave was, despite our efforts to reassure respondents, one of the things that we do, I didn't mention, when we provide the data to organizations, there are safeguards there. So if at a given unit or hospital or whatever level, in combination with all of those different filter options around demographics, work role, et cetera, if at any point the number of respondents drops below 5, then the data are suppressed just to protect the respondent and, minimize any risk of re-identification. Even despite those efforts, seeing some of the data from that 10,000, we've noticed that folks who have responded to the survey that they prefer not to self-identify based on age, gender, Indigenous identity, visible minority status, they tend to have less positive results as well. So despite best efforts perhaps on our part and our client organizations, perhaps a bit of a ways to go still in building that trust and just culture and psychological safety. Yeah.
Kyle, I'm wondering, can you share, like in Canada, not just your global work, how many employers do signed up to do these?
Yeah, by way of accreditation, not all of them have taken the survey yet. Since our 2025 launch, we've had over 165,000 responses to the survey, so a huge data set. Large influx in Quebec, Nova Scotia, Ontario, Newfoundland. And by way of where organizations that are at in their accreditation cycle, perhaps they haven't taken the survey yet. So those who haven't done it yet will be coming in the next probably year or two. So yeah, we're really excited to have that national representative data set. Absolutely.
Good. And Alison, one of the questions coming up, what about Quebec? How are we going to involve it in both of you? But I know, Alison, your project is a project, it's not standard, so we'll have an end date. What you plan to go after that, and if you can elaborate maybe on both of you on the Quebec component. How do we reach out there?
Yeah, great question. So for our project specifically, we have Quebec community health organizations that are a part of the work that we're doing. So some of them sit on our collaborative, other folks that we've connected along the way, we're reconnecting with next year when we're talking about interventions, when there's something a little bit more tangible. But when it comes to that provincial aspect, there's a lot of work to be done. We don't necessarily know if it's this stage of this 5 years of funding where that provincial aspect is where we're going to be reaching out, but it will be a part of what the plan looks like afterwards in terms of how those recommendations come out on a provincial level afterwards.
Yeah, and from our perspective, we were very pleased to see last fall 29 établissements in Quebec mandated the survey for their workforce. So they took that, and very large data set there. If I remember correctly, I think it was upwards of 80 to 85,000 respondents from Quebec. So it was just tremendous to see their involvement and keenness to take the survey. Absolutely.
Thanks. For the viewers, I'm looking at my phone because that's how they summarize the questions to me. And over there, because all of you are writing long questions, but both of you, these are collecting strong evidence and which will develop into policies. But what's your strategies to knock on doors of politicians, on healthcare employer association, on unions association? What's the knowledge transfer questions? How do we change the world with these?
I can go first on this one. I think really just seeing the groundswell of activity. One of the things we've heard loud and clear from our client organizations, who many of them may have workforce surveys of the like in this landscape and have been surveying their staff for many years. But one of the things that may have been challenging for them is as you start to cross perhaps provincial boundaries due to how, healthcare is structured in Canada, difficult to maybe make some of those comparisons. And I draw some parallels perhaps to some of the CIHI data and the wonderful work that Health Workforce Canada has done on that front to standardize data and have that comparability across jurisdictions. And I see perhaps a similar role here for this particular workforce survey as well. Yeah.
Okay. Alan?
Yeah, I think not too really dissimilar in terms of that data piece. We are, likewise, the amazing work that Health Workforce Canada does is we're talking to them about dashboarding, really looking at how do we all work together. We're not trying to reinvent the wheel, right? When it comes to that piece, and very well said by even our working groups as they meet together, is we're a publicly funded healthcare system. We are here for the advocacy piece. So even as we look at what outcomes are going to look like when we look at deliverables coming out of the project. We internally have advocacy, but we are going to be working externally with advocacy. We're going to look at campaigns. We're going to look like how do we bring the public on board. Your impact on your healthcare workers is going to impact your care when you're going to them as well. And I think that's the missing piece sometimes that we don't necessarily see or is translated over. And we want to make sure that's translated over so that they can rally to the government of what needs to change and what needs to be supported along the way. So that will be a really key part of the plan for us.
Thank you. Another question, now I'll put two questions at the same time. One is mostly for Kyle because it's on the HSO. When talking about well-being, are you using any benchmarks and which one? And the second question is on both of you. Have you thought of utilizing the whole occupational health and safety specialist in your work?
Thanks, Linda, and thanks for the question. Yeah, for benchmarks, we're creating our own, absolutely, given that it's a newer instrument. So once we hit that critical mass with data, that is our hope that we'll be able to make those valid and reliable comparisons across jurisdictions and across peer type organizations to give folks a bit of a benchmarking opportunity, and not only to see their own data, but where they stand perhaps compared to their similar type organizations. Absolutely. And then on the second piece around the involvement to date with unions and occupational health and safety groups has been quite low, but certainly with events like this, we hope to increase the profile among those groups and the awareness of the survey as well. And, for the members out there to know that there are organizations such as ours and Allison's and colleagues of the like who take a deep interest and are very concerned with making sure that the workforce is well supported. Absolutely.
Thank you. Allison?
Yeah, and just a very short add-on to that is a number of our working groups do have occupational health and safety workers that are presented in them. And I think what we'll see is larger opportunities in town halls with different various health workforces that can share their feedback.
Yeah, thank you. I'm very proud that our own Title Levitan is on one of your committees, so very proud of that. But yes, it is so important to weave occupational health and safety in all of our work. And as I said earlier, one question here is, Allison, do you know of any funding opportunity for potential intervention at this stage on your project?
Yeah, it's a great question. So, not at this current moment. It's a question that has come up when it comes to interventions as we've chatted about them into next year. We've largely looked into environments and are looking into places where there are already leaders who are ready to make those changes along the way, have ideas that they are wanting to implement or wanting to take from the project, but don't have the availability or capacity to be able to do the pre and post testing. That being said, we continually look at our funding every year. If there are opportunities for us to look at ways where it better serves the project, we are open to those ideas, but not right at this moment.
Yeah, thank you. I know when your project was announced, I was very jealous, saying the least. So I was happy to get an invite to be able to participate. But I'll reiterate all the time when we're talking about wellness, physically and mentally, it's the whole workforce, and it's so important to involve everyone. So I do thank you, and you know that there are many tools out there from nursing and others that we can all use. So it's great. Um, okay. And also, what's encouraging by both of your work, I look at my own budget for CFNU. We spend thousands and thousands of dollars on serving members, serving the working nurses out there. And if we can correlate all our questions, then we have comparing apples to apples and not just saying, oh, that was a union survey. Well, we ask the same thing as the Royal College, and then you're able to compare, but very exciting. I don't have any other questions here, and honestly, we only have a minute to go. So I want to take this time to thank you both. I was a bit nervous about this session, and you two have really thrown it off to a different ballpark on how to bring evidence to life, how to collect the real data. And as I always say, you have the data, you have the information. We do policies or standards, but then we need to bring them to life. My goal in my career is to make these standards mandatory, not just a what if. We need to make it more standardized. So, Kyle and Allison, a big thank you, and fingers crossed and prayers that we will bring physical and mental health wellness to all our healthcare workers out there. But a big thank you to the Canadian Nursing Association, the Canadian Federation of Mental Health Nurses, and the Canadian Federation of Nurses Unions. We're finishing our 3 webinar on wellness in healthcare, wellness within a nursing profession. And I guarantee you, knowing the leadership of these 3 organizations, we will have a lot more to say in the next few months, and we will continue the work on building a safer workplace for everyone. from our patient to all our healthcare workforce. So the nurses out there, stay strong, stay proud, because we're making a difference. Gros merci tout le monde. Bye-bye.